chest tubes, principles, techniques, and pitfalls. Part 1 of this talk will describe the evolution of pleural drainage from the early attempts until today and will help us understand the basis of the physiology behind them. In ancient times, the lung and the pleural space were often affected by tuberculosis, with formation of debilitating chronic cavities, effusions, and empyemas. Bronchiectasis follow the destruction of lung parenchyma and bronchi and add to the chronicity of the disease and to the productive cough or to severe bleeding as demonstrated in this specimen. Before the advent of antibiotics and chest tube drainage, it was not unusual to see patients in whom a chronic pleural and lung infection drained spontaneously outside the chest cavity, the so-called empyema necessitans. The classic symptoms of active TB are chronic cough, blood-tinged sputum, fever, night sweats, and weight loss, which leads to the so-called consumption. Most of these patients eventually died after a miserable and debilitating illness. Also common in the past were non-lethal chest wounds that produce empyema and bronchopleural fistula. Many of them created chronic problems to the affected people. In antiquity, natural selection was very high. Penetrating trauma or incision in the chest were often lethal due to the collapse of the lung and to the inability to manage pneumothorax and infections. Doctors were surgeons by necessity or convenience. They had little training and no concept of asepsis. They performed different operations but could not make an incision in the chest unless in an abscess cavity isolated from the pleural space. They did not have any radiologic imaging. Imagine the dilemma of those doctors who wanted to help but were just a step from being labeled as quacks. Ancient doctors didn't know that the pleural space has a negative pressure, which means less than ambient pressure, which is 1 atmosphere or 760 millimeters of mercury. The negative pressure is created by the natural recoil tendency of the elastic lung and by the respiratory muscles, also by the surface tension holding the visceral and parietal pleura together. This negative pressure would suck air inside the chest through a pleural opening. Therefore remember that during the cycles of breathing, at rest, during inspiration, and during expiration, the intrapleural pressure is usually below ambient pressure, which means below 760 millimeters of mercury, and always below the intrapulmonary pressure. All this was unknown to ancient doctors. Hippocrates deserves the title of father of medicine and that of the first thoracic surgeon for his observation on tuberculosis and the description of incision and open drainage of tuberculosis effusions. These operations were successful as long as the incision opened the abscess cavity without entering the pleural space. Probably more attempts failed than succeeded. Hippocrates taught in the island of Kos in Greece. Aurelius Celsus wrote extensively on the character of inflammation and on chest empyemas. Famous was his dictum that where the pus is, evacuated. Please do not confuse him with the Swedish astronomer Anders Celsius, who invented the Celsius scale, unit of measurement for temperature. He lived between 1701 and 1744. Celsius also wrote on resection and described the use of metal trocars. As previously said, these therapeutic interventions on the chest had some positive results only in patients who already had extensive pleural adhesions. Only in the early 1800s the pneumothorax was extensively described by Itard and his teacher René Laennec. Finally, in 1867, Thomas Hillier, trying to prevent a pneumothorax, opened empyema underwater in a warm bath. This was a totally revolutionary concept. Unfortunately, he died at age 38 from tuberculosis that he likely contracted from his patients. A nice description of this ingenious idea exists in the British Medical Journal, August 3, 1867. In 1875, Playfair, in treating an empyema, solved the problem of pneumothorax by continuous subaqueous drainage of the pleural space. He created what we call tube thoracostomy with a water seal. Without the water seal, the negative intrathoracic pressure would suck air inside the chest and the lung would collapse. Also, this great step in the treatment of empyema was reported in the British Medical Journal in January 1875. The principles applied here are: 1. The column of fluid creates a vacuum behind and pulls down more fluid. 2. The distal end of the tube needs to be kept underwater, and therefore the underwater drainage needs to stay below the level of the chest. At about the same time, Croswell-Hewitt developed a continuous chest drainage, using a red rubber catheter in an antiseptic jar to drain an empyema thoracis. The Hewitt drainage used a single bottle with water or disinfectant to create a water seal. However, since the level of the fluid in the bottle raised with the drainage of fluid from the pleura, there was an increasing resistance to the drainage itself. To better understand this concept, try to suck fluid or to blow air in a bottle first at the surface, then close to the bottom. The latter requires more effort. In 1880, Carlo Forlanini from Italy introduced the concept that TB cavities heal faster if collapsed. In order to collapse them, he created the artificial pneumothorax. The concept of negative intrathoracic pressure and the collapse of the lung in absence of it started to become clearer. Since the lung does not collapse if the pleural is open in the presence of pleural adhesions, the technique of creating pleural adhesion adjacent to a lung process was eventually developed by placing foreign materials in the extrapleural space. The lethal pandemic of Group A streptococcal pneumonia in 1917 and 1918 was associated with a rapid and early accumulation of empyema fluid. 21 million deaths were the catalyst for the renewed interest and study of empyema. The use of open drainage to manage this illness resulted in high immediate mortality rate, probably because patients developed a pneumothorax. Those hospitals, instead, that used the Hewitt underwater drainage achieved much better survival. Eva Graham was appointed by the Surgeon General to the Empyema Commission of the U.S. Army and prompted research which led to the modern understanding of pulmonary and pleural physiology and mechanics and paved the way for most of the recent advances in thoracic surgery. The use of chest tubes and surgical thoracotomies became routine in the battlefields of World War II and Korea. From this research it was discovered that the intrapleural pressure is negative between -3 to -8 centimeters of water, below ambient pressure. If air is introduced in the pleural space, the lung will collapse due to the richness in elastic fibers. The intrapleural pressure changes with the breathing phases. Normal intrapleural pressure are -6 to -8 centimeters of water during inspiration and -3 to -4 centimeters of water during expiration. During forced inspiration, like with the closed glottis or blocked endotracheal tube that leads to asphyxia, the intrapleural pressure may exceed -50 centimeters of water, while during forced expiration, like during coughing, may reach +70 centimeters of water. The drainage system improved when Robinson in 1910 added suction to the bottle and when Lilienthal used 2 bottles instead of 1. This way, the level of the water seal did not change with the amount of drainage. How much suction should we apply to the pleura? The most common suction used today is -20 centimeters of water. This evolved mainly from trial and error. Initially, a commonly used 1-gallon glass bottle was filled to near where the bottle tapered at its neck. The end of the vent tube was then positioned about 2 centimeters from the bottom of the bottle, so that the tube was submerged about 20 centimeters, which in turn controlled the pressure of the vacuum in the system. This works most of the time by creating a negative intrapleural pressure of about -6 to -8. In 1952, Howe introduced a third bottle to regulate the amount of suction by moving the tube in communication with the ambient air up and down in the water. This arrangement serves as the basis for almost all thoracic drainage systems in use today. Here is clearly visible a 3-bottle system. On the right, the suction or manometer bottle with the immersed tube in communication with the ambient air. This tube can slide up and down to regulate the suction. In the middle, the water seal bottle, and on the left, the collecting bottle. Therefore, it took almost 80 years to develop a modern chest drainage system. Here you can see the three functions of collecting, water seal, and suction in 1, 2, or 3 bottles. And this is the way one of the many modern chest drainage unit, otherwise called CDU, looks like. I hope you enjoyed, and I hope I will meet you also in part 2 and 3 for more on the topic of chest tubes, principles, techniques, and pitfalls.